Well, hello and welcome to episode 2 of the Healthy Skeptic MD podcast. I am Dr. Michael Hochman, your host. The purpose of the Healthy Skeptic MD podcast is to take a deeper dive into the health news with a critical eye and try to separate the wheat from the chaff. If you like what you hear today, I have a YouTube channel, Healthy Skeptic MD. You can also find me on whatever podcast listening device that you use, also on Instagram, and I now have an email address, healthyskepticmd@gmail.com. So I have a great interview today with New York Times bestselling author Katy Butler. It's a really good interview, so stick around for that. But first, let's go through the health news of the week. And I'm actually going to begin with 2 questions I got from listeners from episode number 1. So the first question had to do with the interview that I had with Dr. Brad Spellberg. Both Dr. Spellberg and I expressed some skepticism about 2 of the FDA-approved treatments for COVID. The first was convalescent plasma, and the second was remdesivir. As a reminder, convalescent plasma is antibodies from someone who has recovered from COVID and giving it to someone who is struggling with the disease now to help their immune system. I'll begin by saying the FDA has a very hard job right now. They have to balance appropriate pressures to get medications to patients quickly with the usual rigorous scientific process that they need to go through. So they do not have an enviable job right now. Nevertheless, I do think they jumped the gun a little bit on convalescent plasma. And the reason for this is that the one rigorous trial did not show a benefit. And the concern is that by authorizing the medication without strong data, we potentially risk exposing patients to the treatment, which may not work, and they may experience complications and side effects. And certainly there are some potential immunologic concerns with the medication. In contrast with remdesivir, I actually do think that they got it right. And to begin with, it's important to point out that the FDA did not actually approve officially remdesivir. Instead, they provided what's called an emergency use authorization. And this allows patients to get the medication right now in the middle of this pandemic, but it acknowledges that there's important data limitations and that more data is needed in order to grant that official long-term approval. And I think this is right because there's some evidence from the good studies that it works, but it's not solid. So both Dr. Spellberg and I pointed out, for example, that many of the outcomes where there was a benefit are subjective. So the studies did not show, for example, a clear mortality benefit from remdesivir, but rather it showed a subjective benefit as judged by the doctors taking care of COVID patients. The second point is that certainly in one of the pivotal trials, the patients who received remdesivir, the doctors knew which patients got the medication and which got the matching placebo. So this certainly could have biased their judgment. And the third concern is that there was some inconsistency. So in one of the trials, a 5-day course of remdesivir was effective, but a 10-day course wasn't. And of course, you would expect that a 10-day course would be effective. So there's an inconsistency there. So that first question was from a listener in Boston. Thank you for that good question. And the second question is from a listener here in Los Angeles. And he was asking about some of the reports that have been in the media this week about athletes who are being shown to have inflammation of the heart on MRI scans. So a JAMA report just published this week substantiated that, and they did MRIs of 26 athletes with diagnosed COVID, and they did MRI scans of them, and they found that 4 of them had active cardiac inflammation, which is known as myocarditis, and another 8 showed evidence of possible prior cardiac damage. So the question that this listener had is, should we be worried about this? So the short answer is we need to take it all in stride. So to begin with the good news, we certainly do not see an epidemic of people, certainly young, healthy people, dying left and right of cardiac complications from COVID. So even if these folks are showing some evidence of inflammation on the MRI scan, it does not seem to be leading to serious life-threatening complications in most cases. The second thing is we don't really have the context here. So we don't typically, when someone has a viral infection like the flu or mono, we don't typically get an MRI. And it's quite possible that if we did, we would see for many of these other common viral infections that there is this inflammation. Nevertheless, myocarditis is a serious complication, and I don't want to totally dismiss the concerns. I think, as always, we want to use good judgment. If you have COVID infection, and you have shortness of breath or chest pain or any other worrisome symptoms that would typically go to the doctor, please do so and be evaluated as you would. Secondly, I'll say listen to your body. I certainly don't want to encourage everybody with COVID to lie in bed all day. On the other hand, do not push yourself when you're sick. This is not the time in the middle of a COVID infection to pick up a hobby like marathon running. Your body will tell you when you're comfortable resuming your normal physical activity. The final point here is everyone with COVID infection does not need to rush out and get an MRI. The first thing is, even if you were to see inflammation on the MRI, there's no approved treatment for it, so we wouldn't do anything differently, and it would just lead to a lot of concern for what is probably a very low risk situation in terms of serious complications. So thanks for those great questions. If you do have any questions about anything that comes up today, feel free to email me, HealthySkepticMD@gmail.com. There are 3 studies I want to just very briefly mention to everybody before we get into our interview. So the first study I'll mention is a new study showing that there's more evidence of psychological harms from the COVID-related closures. This one comes from China. Among Chinese school children, the percentage reporting symptoms of depression from the pre-pandemic period to the post-pandemic period increased from 18.5% to 24.9%. This is a good reminder for all of us to be mindful of the impact that the pandemic is having on our emotional health. The second study is from the Annals of Internal Medicine. That's getting a little bit of media attention. It was a survey of 991 U.S. adults, and it found that only 57.6% reported that they intended to get the COVID vaccine when it does hopefully become approved. Another 31.6% were unsure, and 10.8% actually said they did not intend to get it. Now, this is important because it just highlights how important it is for whatever vaccine gets approved to be rigorously evaluated. The scientific community is going to have to be confident that it is safe and effective if we're going to be able to get the public behind this vaccine. And we need to, of course, be able to communicate this effectively. And this is all, of course, dependent on actually there being an effective vaccine, which I'm optimistic about, but of course is not a sure thing. And then the final study I'm going to mention is a report from the Centers for Disease Control that looked at risk factors for acquiring COVID. Unfortunately, this is not good for those who like to dine in restaurants. I had found that one of the strongest predictors of acquiring COVID infection is on-site eating and drinking. So this might be in a restaurant or in a workplace. This, of course, makes sense because when you eat, you have to remove your mask, and COVID spreads through respiratory droplets, and without a mask on, those can very easily transmit from one person to another. So I think the take home here is, to the extent feasible, try to avoid eating in close proximity to others. Ideally, if you can, in an outdoor environment at a table that's separated from others. I do notice that some states are starting to allow indoor dining again, and that is something I would be cautious about for the moment anyway. Okay, so now we are going to transition today to today's interview with New York Times bestselling author Katy Butler. All right, well, let's jump in today. So today we are very lucky to have New York Times bestselling author Katy Butler with us, who has really been a very prominent writer and has gotten ideas out, and as we'll talk about, has started a Facebook group called Slow Medicine, where we have discussions about many of the things that we speak about on this podcast. But let me begin by just saying I first became introduced to Katy in 2010. It was right after I completed my medical training, and a friend of mine passed around an article that was in the New York Times weekend edition, and it was what broke my father's heart, and it was a really poignant story about the chain and cascade of events that happens to her father after he had a stroke in 2001. And many of the medical interventions that really happened to him in isolation might have made sense, but the sum of the parts was not in alignment with his goals of care. And it was right when I was finishing my medical training and starting to have these same feelings that I myself was becoming part of this medical machine that was doing things to people rather than a partnered decision about what their healthcare should be. And I, to this day, is the most powerful medical piece I've ever read, which is why I've chosen to have Katy on so early on in this podcast series. So, Katy, could you just begin? You've done so many interesting things in your life, from following Eastern religions and writing for prominent media organizations. Could you just mention a couple highlights that you've had in your career?
Sure. I think I've just always just followed what I was deeply interested in, and that's led me in a number of different places. I worked for the San Francisco Chronicle as a city-side reporter for 12 years. I did things like go onto the streets as a homeless person and live homeless for 3 or 4 days and then write about it at the very start of homelessness as an issue that we were aware of. And then I was very involved in reporting on the AIDS crisis because I was in San Francisco and I had, of course, gay friends. And I ended up writing not only for the paper about it, but also for the New Yorker, writing short pieces about the spiritual and the creative responses that were coming out of the AIDS crisis. So there was a wonderful Catholic church in the Castro, for example, which was called the Gays and Grays because there are a lot of old widows and young men, and they really came together as a community. And the AIDS quilt I wrote about very, very early when there were only like 70 or 80 panels. And so anytime anything really deeply moved me and brought me to tears, I knew I should write about it and discover more about it. And that's pretty much how my career has gone. I spent a decade writing about psychotherapy for a psychotherapy magazine, which really taught me how to read a medical study and to also become skeptical about big promises in the medical world, because there's always a new promise every year. So I think that's it. And I think also from the beginning, I've been willing to meld my personal life and my personal journey with what's going on in the larger society. I'm a baby boomer, and so for many decades, I knew that if something was deeply concerning to me, there was a very good chance that there was a huge population bump for whom it was also a very live issue. So I became a Buddhist in my 20s, and that's turned out to be a big thing. I guess I didn't know it at the time. I was
You're
like an
ahead of the
early
curve.
adopter, yes. But it's, all this stuff about mindfulness now that has since come. So I don't know.
So,
Yeah.
Katy, that's exactly what you did in 2001 with your father's experience, and you turned it into something that you were able to write about and bring out larger issues. I know it's an impossible thing to encapsulate in a 30-second soundbite, but could you just give the listeners a real brief overview of what happened to your father?
Sure. If you wouldn't mind, I'd like to read just 2 paragraphs from the story because I pulled it out
Please.
yeah. And I think they might actually do a lot of the work of a summary. Okay, until 2001, my 2 brothers and I assumed that our parents would enjoy long, robust old ages capped by some brief, undefined final illness. Thanks to their own healthful habits and a panoply of medical advances, they weren't likely to die prematurely of the pneumonias, influenzas, or heart attacks that had decimated prior generations. They were seemingly among the lucky ones for whom the American medical system, despite its fragmentation, inequity, and waste, works quite well. They were also Stoics and religious agnostics. They'd signed living wills and durable powers of attorney for health care. My mother even had an underlined copy of the Hemlock Society's final exit in her bookcase. Even so, I watched them lose control of their lives to a set of perverse financial incentives for cardiologists, hospitals, and especially the manufacturers of advanced medical devices, skewed to promote maximum treatment. At a point hard to precisely define, they stopped being the beneficiaries of the war on sudden death and became its victims. So what actually happened was that my dad had been very vigorous and healthy till the age of 79, had a major crippling stroke. 2 years later, as he was starting to descend into dementia, never having been able to retrieve independence, he was given a pacemaker. And I'm sure your listeners are going to be very interested kind of in the process. He refused a pacemaker once. He had symptomless bradycardia. No symptom, no problem. So actually, according to the guidelines, he shouldn't have had a pacemaker. Turned it down once, then had the stroke, deteriorated, needed a hernia surgery, and the cardiologist would not give him a clearance for the surgery unless he had a pacemaker beforehand. So it was kind of this cascade, this stampede, this unnecessary sense of urgency. I mean, he was in pain from the hernia, but clearly he could have gotten a truss, just given this a little more time to think things through. I was in California. My mother was opposed to it, but kind of shrugged and went, well, I guess we don't have a choice. And so the pacemaker went in. I was very dubious, but at that point I didn't have any language. It was like, what's wrong with you, Katy? Don't you want your father out of pain? Don't you want your father not to die? That guilty inability to articulate these deeper issues, which our whole culture is having such a hard time articulating. And so then his decline continued. He really became demented and miserable, going blind from macular degeneration. And finally, about 5 or 6 years into this, my mother said to me, can you help me get this pacemaker turned off? And I can remember my heart just knocking. And I just knew it was something I had to help her try to do. Unfortunately, we got no cooperation from the cardiologist, who in fact later told me that it would have been like putting a pillow over your father's head. And even when my father got pneumonia and was on hospice, and in an inpatient hospice, we could not succeed in getting a medical order to turn off the pacemaker, to deactivate it, even in those 5 days of his dying. So some of this, sure.
I want to go back because there's such an important point here. In the beginning, when the pacemaker was first implanted, there was a part of you, and it sounds like your family as well, that had questions about whether this was the right thing to do. Why did that give you pause?
Well, I knew that my father was already in the most unhappy period of his life, and one that didn't seem to offer any redemption. My father had lost his arm in the Second World War, but he had bounced back from that very successfully, really, even though he lived as an amputee all his life. He had a great life, but this was not something he was going to recover from. My mother was also completely exhausted. She had become an 80-hour-a-week caregiver. And I personally believe that when there's a blow like this to a family, the entire family is the patient. It's not only the individual, it's the entire family system. And so, I mean, looking back on it, I could say, what was the point of giving my father some additional extremely poor quality years at the price of probably destroying my mother's health and some of her moral fiber, frankly, in those 6.5 years that she was his caregiver?
Now, having witnessed a lot of patients get pacemakers and implantable defibrillators, a lot of times the way it's presented is this is a life or death situation. And if you don't take this pacemaker or this implantable device, the heart might stop. How come, were you concerned that if you turn down the pacemaker, that would shorten your father's life?
Well, I hate to say this, but I felt then and still feel that my father outlived his happiness within a year or two of that stroke. So giving him additional years didn't feel like a blessing to me. It actually felt like a curse. And he felt that way too. Towards the very end of his life, he said to my mother, "I'm depressed. I'm living too long." I think at the point where she actually asked to have the pacemaker turned off, she had become very clear that not only for her own suffering as a caregiver, but also for his suffering as a human being, this was no longer a, a charitable, a beneficial thing to be doing to him. I think there's almost a taboo in the society against saying this. It's like we're always supposed to think that life is a blessing. And for most of us, for most of our lives, if we're lucky, it is a blessing. But there does come a time and a level of suffering, whether it's emotional or physical, where the balance just shifts and people are secretly saying under their breaths, what are we doing this for?
Well, right when I read your story, I had a patient that I was covering the inpatient service, and he had gone in for his primary care doctor, and he was having a little bit of shortness of breath, and maybe
Mm-hmm.
one approach would have been to adjust his blood pressure medications. But in any case, he ended up getting a stress test, and he was in his mid 80s. Now, thinking back on it in retrospect, one question would be, well, what will we do if the stress test is abnormal? Does it make sense to sort of send ourselves down this path? And a lot of times that's where that decision is made. And in any case, he ended up getting that stress test, and it showed an abnormality. And the next thing he knew, he ended up on the cardiac catheterization lab, and they were trying to put a stent into his heart. And then, as similar to what you experienced, one medical procedure often begets another. And the next thing is, after the procedure, he had a heart arrhythmia, and his heart rate was low, and he needed a pacemaker. And they also noticed on the echocardiogram that his ventricle, the heart muscle, was dilated. And he technically met criteria for a biventricular pacemaker, which is a bigger procedure when the pacemaker goes on both sides of the heart. And since they were in there anyway, they might as well put a defibrillator in there. And this poor guy, I remember talking to him right after the procedure, and he kind of joked, but he wasn't joking, that I just came in because I had a little shortness of breath. The next thing I know, here I am. And I was early in my training, and I decided to give him a call a couple weeks later. And I said, how are you doing? And he said, well, I was started off short of breath, and now I can't even go on my weekly walk to the grocery store that I used to really enjoy doing. And this was just a terrible decision for me. And I heard that perspective, and then I talked to the attending cardiologist, and there was no insight about what had happened. There was no knowledge about what had ended up happening to that patient. He just assumes that, like in the studies, that the patient was living longer, and that his procedures and devices had enabled this person to live a longer life. And so your story really resonated with me, and it's not only just about length of life; it's quality of life. So what advice would you give to somebody who is faced with a situation like that, where they have a medical specialist telling them that they really need something? Is there a buyer beware sense that we should have?
Well, it's interesting what you just said, because in my second book, The Art of Dying Well, I have similar stories to that. And I just want to comment on the big picture for a minute, which is, first of all, this phenomenon of treating the test. So the more tests, the more problems you're going to find. And then you treat the test rather than treating the person, like exactly this case that you talked about. The other thing is that the system is so fragmented that surgeon, there's no reason that surgeon would ever know what the results were of that surgery on a quality of life and functionality level. He's going to know about his 30-day survival statistic, and that's what he's going to be judged on. And if you're a family member, and the books that I write, I'm writing from the bottom up. And so I'm writing from the point of view of like the phone call that you made to that guy. And we have to look at it from the results point of view for at the bottom, from the bottom up, rather than the criteria from the top down. And of course, because the system's so fragmented, there's no reason for doctors to be getting this feedback. There's no feedback loop in the system to allow that to happen. So I think that's why I write books for lay people. And I try to give them the lay of the land and the landscape, and to understand the perverse financial incentives in medicine that might drive these decisions. I mean, I know a lot of them are not driven only by financial incentives. They're driven by the nature of medical training, the impulse to do the right thing, maybe a certain kind of naivety about the results. So I try to say to people, I mean, one of the principles of slow medicine, especially for older people, is that you can slow down on these decisions. They tend not to be as urgent or time defined as they are often presented. You know, if you have a stage 4 cancer, you do have a weekend, you do have a week to cry with your family and to think about things and see a social worker or see a palliative care doctor. You don't have to rush into it. You know, yes, if you've got an exploding appendix or you're just in a car crash, that's very different. And then you're going to rush in and say, thank you for fast medicine. But a lot of these are slow medicine decisions. The other thing I try to do, and I tried to do it a lot in that second book, The Art of Dying Well, is you got to understand the health stage that you're in. Because in vigorous early old age, which is where I would put myself, I'm 71 now, but I swim almost every day. I don't have any health problems or drugs that I take. The decisions that I could make around a potential surgery might be very different from someone that I would say, someone who's accumulating a lot of ologists. You know, they're in a slowing down stage. They're getting more fragile. You want to deal more with modest tinkering rather than, you know, big time solutions. And then I talk about this stage called the House of Cards, which I think is perhaps the most important and under-recognized health stage of all of them, which is, it's the Humpty Dumpty stage. People like your guy in the 80s, they cannot take a major stress. They may not be able to take a 3-day hospital stay without pirouetting down into hospital delirium and then having a 3-week stay in a rehab that they're unfamiliar with. And just the unfamiliarity of the environment alone may be enough to stress them and into, you know, real come down. And so I think this understanding of the interplay between what the test says, who the person really is, what they value, what matters to them, like your guy. He wanted to walk down to the corner. He wanted to walk to the grocery store. Maybe he wanted to play cards with his friends. Who knows what it was that mattered? But treating everything on the checklist of all these tests was certainly not it.
Well, one thing I really realized the further along I get in medicine is there's no single right way to do things, and there's different paths and avenues and different tools that the healthcare system has to offer. And what the right tool is for one person may be very different based on factors like the stage of life that they're in, the stage of aging. And I want to come back to this because you have a very elegant way of describing it in The Art of Dying, which is your most recent book. But one question that I often get when I suggest that we really have a thoughtful decision about whether or not to do a procedure is, if I do choose to get a second opinion or I don't follow the recommendation that the doctor has, is that going to offend him or her? And is that going to lead me to subsequently get worse care? And what would you say to someone who feels that way?
Well, I think in my writing, what I really try to do is empower people to feel some confidence about their own gut thinking and their own common sense. Mm-hmm. But I also really resonate with that because as a patient, you do feel very disempowered in the system. It's hierarchical and you feel kind of like the supplicant. And so I understand that fear. And I guess I mean, it's easy to say and harder to do, but it's that it's okay for you to fire a doctor and find someone else. You do need someone who is at least curious about what matters to you. Um, in my second book, I talk about a woman named Amy Berman, and the first oncologist says, here's what we're going to do. And he lays out a very intense, aggressive treatment for stage 4 cancer. And then she goes back to just her garden variety oncologist who says, what do you want to accomplish? And I just think the difference between those two questions, here's what we're going to do versus what do you want to accomplish, is so important. So I think it is a risk you take. You could alienate a doctor and you could feel bad about it. But if the relationship is that fragile as it is, maybe it's not the right one for you. I
Well, I
also
agree.
know, yeah,
I was going to say I agree with that, and I tell people that if the doctor does get offended, that's his or her problem. That's not your problem. And I think too many times patients forget that we, the doctors, the nurses, the healthcare system, we're there for them. It's not the other way. And I think too often patients feel like they're there to do what their doctor tells them.
yeah. And as my husband always tells me, you're the customer. You're the customer.
Yeah, and the other piece of the pacemakers and these interventions, I think there's also a skewed sense of how great the benefit is. So with a defibrillator, for example, most of the studies show that over a several year period, you'd have to implant about 100 people to extend one person's life. So the vast majority of people don't actually benefit from the device itself. Now, if you're, as you said, a young, otherwise healthy person, that's very much worthwhile. It makes complete sense to want to extend your life as long as possible. But if you're in a more fragile state, in that house of cards state, for example, and there's a chance that this procedure is going to set you back in terms of quality, even if it does extend your life a little bit, which it may not, that very reasonably would be a decision not to proceed.
And unfortunately, and again, lay people don't know this, that most of the studies are done on younger people, but then most of the devices go into older people.
Right.
So we don't even really have a clear landscape of how beneficial an intervention is, and especially for people with multiple fragilities.
Now, I want to come back to your dad's story because it
Sure.
is so compelling. So your mom came to you and she said, "Katy, help me get us out of this situation." What happened next?
Oh, I called the I called the cardiologist, and he was about to go on vacation. He scheduled, I think, a 15-minute phone call with us. It was extremely harsh on both sides. I think I didn't know him. He didn't really know us. He'd seen my father, I think, twice for 15 minutes. It was not like a developed relationship. And I can't remember exactly what he said, but it was clear that he was not going to help us. And then my mother and I went downstairs and sat on the couch and held each other and just shook. I then called the family doctor, who we were very close to and was very much in a line, really loved my parents. And he said, I'd help you if I could, but I don't know how to turn these things off. But he said, you know Jeff. My dad was Jeff. You know him, you love him. You're the ones who've been taking care of him. You know best what's best now. And he also was very clear, Jeff can't communicate with me anymore. He used to be able to sort of, get a message across. And now all he does is smile and nod no matter what I say. At that point, I was a journalist already. I mean, I'd been a journalist for 30 years, so I have critical thinking, independent thinking, question authority, all of that. So of course I went online, looked around, try to find a cardiologist who might be more sympathetic to hospice. But at that point, I don't think I even knew the term palliative care. And plus, it was pretty new. It was about 2009.
Mm-hmm.
Um, so at a certain point, I just gave up and we just continued. But at least I got into it enough to know that this was a real question in cardiology and that there was a debate about these issues. It also became much more clear to me over time that the pacemaker can actually be a very beneficial intervention for a lot of people. In my father's case, it made no difference at all because he had no symptoms to begin with. But that the defibrillator was, more and more cardiologists that I talked to about it really kind of considered it the device from hell, frankly, that really created enormous moral questions.
Yeah, so I know it's not the easiest thing to discuss, but how did things end?
Oh, so 6.5 years after the original stroke, after my mother and I failed to get the pacemaker turned off, she put her foot down and rebelled to a degree that I didn't really realize until I got her journal after she died. And she essentially said, I've had it with all these interventions. She refused some kind of nuclear heart testing for my dad. She refused to put him on warfarin. And she said, everybody's talking about quality of life, but what about mine? And she started to just cancel all of these meaningless monitoring these meaningless monitoring ology appointments, all the subspecialists who were doing nothing to change the picture on the ground, but were testing and keeping notes, the neurologists, people like that. And I was, meanwhile, like trying to follow, I got in contact with Compassion and Choices, which had a very good warm line for advice. And she advised me to get my father taken to basically a neurologist to get it confirmed that he was no longer could make his medical decisions. And so we were kind of working on that track. But meanwhile, the family doctor put us in touch with a palliative care team, outpatient team, that came to the house. Because my father was starting to fall repeatedly and get into that cycle, that ER, hospital, horrible hospital stay, home again in worse shape cycle. And they were a godsend. And we were taken care of by a team, And that really changed things. And then I think 2 or 3 months after that team became involved, my dad developed pneumonia, and there was just a very clear, unspoken decision not to treat. And he was transferred to an inpatient hospice unit that was wonderful at the local hospital in Connecticut. And he died there over the course of, I think it was 5 days. And even that I found absolutely agonizing, even though it was pretty much as good as it could have been, with the exception of the fact that we couldn't get the pacemaker turned off. The care was beautiful. We could just be there as family members. We didn't have to be breaking our backs doing all the bedside care. His death was peaceful. I had the opportunity to get him given last rites in the Anglican Church, even though he hadn't been to church in, 30, 40 years, but it was very soothing and helpful to me. But my mother and I were both extremely clear. We were doing your own kind of do-it-yourself comfort care, although I had not even heard that term at the time.
Well, I love how you found so much positivity in what was an incredibly painful and difficult situation. Now, a couple terms that you mentioned, palliative care and hospice, and also comfort care. Yeah. I find them to be some of the most misunderstood terms in healthcare. What's the difference between palliative care and hospice care?
Okay, I'm going to talk in 2 different ways. I'm going to talk about the ideal, and then I'm going to talk about the reality on the ground. So the difference between palliative care and hospice for lay people, I think that's most important to realize, is that palliative care is parallel to curative treatment. You don't have to be on the brink of death. You could have any kind of chronic serious illness and really benefit from palliative care. Palliative literally just means to kind of soothe a situation rather than try to fix or cure it. And I think palliative care really should be a bigger umbrella. Rehabilitation is a type of palliative care. Supportive pain management, exactly. Psychological help, coaching with medical decisions. That's a huge part of the role that palliative care plays. Unfortunately or not, palliative care is also used by institutions to deliver bad news that oncologists and cardiologists and nephrologists have failed to deliver in a timely manner so people can really be up to speed on what's going on with them. Palliative care is often used for final medical decision making. For example, if someone ends up in the intensive care unit on a ventilator, it's no longer going to get anywhere. It's no longer appropriate to have those very difficult conversations with families to help them make a decision whether or not to end aggressive treatment. However, I've got to say something here, which is that some institutions use palliative care to do that very last minute work. And as a result, palliative care is getting widely misunderstood in the general population. Because once you see some family member of yours not getting any kind of support or pain management or anything else, and then 5 days before they die, suddenly someone says, well, we're referring you to the palliative care team. And somebody comes in and says, well, I'm the quality of life doctor. How much do you understand about what's been going on for the last 8 years? And the answer is not much. That is going to give palliative care a bad name, okay? So this may sound like a long digression, but so the difference is, of course, that hospice is a benefit that you can access at home or in a hospital or in assisted living. It's a team approach to give you the highest possible quality of life and the highest possible quality of death. It's a 6-month benefit in most insurance, including Medicare. Some allow it to be a 1-year benefit, which is wonderful. And so I think the distinction is that palliative care can segue into hospice very beautifully, as it did for my dad. Or palliative care. I have a friend who was in palliative care for, I think, like 23 years. She had a managed stage 4 cancer, and she was able to maintain a high quality of life for years and years, decades. And she had both an oncologist with very low social skills and a palliative care doctor with very high social skills. And the palliative care doctor would actually help her, coach her on how to interact with her very, very talented oncologist. So did that help, or did I go on
Absolutely.
too long?
And I think you said exactly what one of my biggest articulated one of my big frustrations is how palliative care has been misbranded as death panels is how it's been termed, when in fact really what it is an extra service that focuses on comfort and symptom management that enhances the other care that you're getting. And I don't even necessarily think of palliative care as always end of life care. Everything from symptom management to helping us live more comfortably at any stage of life, whereas hospice is more about living the best death possible, and there's the 6-month time frame and so forth. But they certainly, as you said, can blend easily into each other. The other big misconception is the implications of palliative care. And there was a landmark trial that I wish got more attention. It was published about 10 years ago by a Harvard doctor, and it was a randomized trial, the most rigorous trial we have. And they took patients with a new diagnosis of lung cancer that was end stage. It was not a curable situation. And half of the group got early, immediate palliative care, and the other group didn't. Both groups got the cancer oncology treatment. And the thinking was that probably the group in the palliative care arm, the hope was that they would be more comfortable. And maybe they wouldn't live quite as long, but at least they would have a higher quality of life. And indeed, that happened. Depression scores were lower, quality of life was higher. But the real surprise was that actually that group lived longer than the group that didn't get the palliative care. And I think there's not a more compelling piece of data that palliative care really is an extra form of treatment. It actually helps people live longer. So that's one thing I always try to really emphasize to my patients. Choosing palliative care does not mean giving up. It's actually really an extra service. And the same is true for hospice. It's an extra benefit that allows you to live more comfortably when we really are out of curative options or life prolonging.
I agree. And yeah, I'm familiar with that study. And I was curious as to why could this possibly be true? And then when I talked to more people on the ground level, I started to understand. In that book, The Art of Dying Well, I interviewed a woman. She had gone for chemotherapy for pancreatic cancer, but then there had been one of these cascades. So the chemo was too much for her. She was 85 as it was. She ends up in the hospital. She gets C. diff. She almost dies from C. diff. So I think that's partly why those statistics show up the way they do. That is, when you're doing these very, very harsh treatments, you may end up in the hospital, and medical errors are, prolix in hospitals. And that collision between your vulnerability and the difficulties of the institution can collide disastrously.
I think that's very well said, and I think is probably a large part of the explanation, the number of iatrogenic complications that come, and palliative care helps us skirt around those problems.
And that woman that I just described to you, she then, she was skeletal. Everyone thought she was like 2 weeks from dying. She goes on hospice and lives another 9 months.
It's a perfect anecdote that explains that data, which I think is the reality. So Katy, after your 2010 article came out, your work didn't stop. In fact, it sort of led to a new line in your career and a new direction. And you've done a lot of work advocating for palliative care services, for dying healthy and well. You wrote a book, Knocking on Heaven's Door, which was a more in-depth description of your own personal experience with your father, another really poignant book. And then you tried to put it together in a checklist format with The Art of Dying Well. Sort of the Cliff Notes version is the way I think of it. I hope that's an okay way to describe it. And you also started a group where I got to meet you. I had read your work, but I actually got to interact with you directly through your slow medicine group. What does slow medicine mean? You described it a little bit before, but give us another definition.
To me, slow medicine it's really an international movement. And it actually was started by cardiologists in Italy. But it's an international movement from both the patient side and the doctor side, or the medical side, saying doctors need more time with their patients. They need to have relationships. They need to be thoughtful. And this is a joint enterprise. And in a way, it's easiest to describe it by comparing it to fast medicine, with the equivalent of fast food. Fast medicine is thinking that if you throw the maximum number of goods and services at a person, enough of them will stick so that they will bloom into health. And the slow medicine equivalent is to say, well, there may be some situations where that's perfect, like the ER. Fast medicine couldn't be better. Heart attack couldn't be better in the immediate. But slow medicine is the fact that 80% of us suffer from chronic, slowly debilitating conditions of various kinds. And those respond much better to thoughtfulness, to sometimes minimalist treatment, depending on the degree of fragility of the person, their values, but mostly that time in medicine is at least as important, if not more, than these advanced technologies that we've developed in a lot of situations. So it's almost like an ideological movement or a counterculture within the medical world, and it goes against a lot of the other trends in medicine.
Yeah, I think that's right. And, it's a term that I've used and has really resonated with me, but I think you're exactly right. It is counterculture, but it shouldn't be, because it's sort of the yin and yang. You need the balance, of the thoughtful, deliberate. We have this tool, but should we use it, and in which cases? So I love the term. And one thing, I'll just make a quick plug. I think, Katy, if any of the listeners would be eligible to apply to be part of that Facebook slow medicine
Please
group.
do. Yes. It's an amazing cross fertilization because you have some people who are terminally ill. You have a lot of family caregivers dealing with people in their 70s, 80s, 90s, people who are aging themselves, and then this incredible cross section of medical professionals, hospice nurses, doctors, social workers, the whole panoply. And so you have some fascinating conversations and not always agreement, but it's lovely.
So, Katy, I want to fast forward ahead and hear your thoughts on how some of what you've learned might apply in the current environment with the COVID pandemic. But before I do, could I just ask you one more time to outline the stages of aging in the art of dying well? Because for me, that really helps me guide my thinking about patients.
Great. I hope I can remember them all in the moment. Essentially, I divide these health stages, and at each health stage, there's a pivot in your relationship to your expectations of medicine and maybe which treatments you want to go for and which ones you don't. So it's a progress from green light to yellow light to red light. I start with vigorous, healthy, young old age, which I sometimes call resilience as a stage. You can take a intense medical intervention. Then I have a stage I call slowing down, which is when you're starting to accumulate your ologists and you need to watch out for polypharmacy, for example. Then move on to coping with some degree of disability and the kinds of medicine that are really helpful to you at that point. Then the house of cards, which I think, as I said, is really the signal stage to recognize when you have multiple fragilities due to age or maybe multiple comorbidities, where again, there is a strong shift in your relationship to medicine and what will benefit you and what won't. Then there's preparing to die. There's getting your ducks in a row, those last 2 years of life when you're shifting more and more away from intense medical intervention and paying more attention to emotional and spiritual and clean things up stages of life. And then finally, those last 5 to 10 days of active dying. And at each one in the book, I have a checklist at the beginning of the chapter so you can see whether you belong there.
Well, it's a book I recommend to my patients, especially those who are sort of reaching that stage, to help be systematic and think through all these types of questions. So if you're interested, it's The Art of Dying Well, and it's katybutler.com website, and you can also access it through the Facebook Slow Medicine group.
And also just through Amazon, or even better, your local independent bookstore.
Well, let's talk a little bit about COVID. I know it's an issue that you've thought about. You've written a couple op-ed pieces. We've even written one together. Does the current pandemic, does it bring to the forefront some of these issues that you've been mentioning about, the healthcare system making rapid decisions before people have really had time to process and digest whether it's the right thing for them?
I think it's an awfully big challenge. And in some ways you could say, yes, it makes it even more important that you have an up-to-date advance directive, or you talk to your kids and your relatives about what matters to you and what doesn't. And in other ways, I think it's made it even more challenging. because at a time when a horrible new disease floods the world, people don't want to hear about accepting and befriending death. They want to hear about avoiding death. And you know how they talk about this, the stages of dying, which have been challenged quite a bit, but there's denial, there's bargaining, and then there's sort of depression and acceptance. And I think as a culture, we've been in denial and bargaining very, very heavily for the last several months. Like, if only we all stay home, this thing is just going to go away completely. Or if only we pay, throw enough money into Operation Warp Speed, we're going to have a vaccine by Christmas time. A lot of, frankly, to me, completely unrealistic hopes. So I found that in some ways there has been less interest in what I have to say during this period. But there's also been this sharpening. I was on a call with Ira Byock, who's a real leading hospice doctor, and he's probably about my age, a couple years older, and he said, I could be dead in a month. And I thought, oh my God, that's actually true about me. I have just a little bit of bad luck. However healthy I think I am, I'm still 71. I could be on that assembly line conveyor belt to the ICU, to a ventilator that is unlikely to do me much good, and I could be dying exactly the death I have spent all this time trying to help people not to die. In fact, I had a conversation with you where I was trying to figure all this out. I was calling all my friends who are palliative care doctors and saying, what should I do? Should I redo my advance directive and say, in case of COVID, anything up to intubation, but not intubation? And in fact, I have a friend, Stuart Brand, who founded the Whole Earth Catalog. And he and his wife took my book, because I have a dementia directive in my book, and it's very plain English language, common sense. He took it and essentially hacked it, and they created a specific COVID advance directive that said yes to supplementary oxygen, yes to a mask or a cannula, yes to going to the hospital, yes to proning, and no to intubation, because he's in his early 90s. The chance of him getting out of an ICU intubated are infinitesimal.
And even if he does, he may not come out the same person he went in.
Exactly. And these long ICU stays, as you know, the chances of people actually coming back to something that looks like a life that they consider worth living is low, and it goes up and up. The risks go up and up with age. With every year of age, the worse. Then, of course, but COVID's very complicated, because now they're using, what is it, dexamethasone or something?
Dexamethasone, yeah.
Yeah, which is reducing mortality by a third. But again, I wish we were seeing more age segmented research on this, because those of us, it's this interesting interplay between the concept of aging, of ageism, and the concept of being clear-eyed. I hear a lot of people say, well, we can't just sacrifice the very, very old. They deserve all the services that anyone younger should get. Or, isn't it terrible this nursing home did not send this 80-year-old to the hospital when they were dying of COVID? But I, as an older person myself, I don't see it that way at all. I mean, if my chances are, less than substantial, I want to know that. And I don't consider I'm being deprived of health care if someone gives me the lay of the land and gives me the opportunity to make my own choice.
Well, the trade-offs are very different in people of different age groups in different situations. So a young person who were to suddenly get very ill, not only would they have a better chance of making it through if they received aggressive care like intubation, but they'd have a much better chance of coming out of it with a much higher quality of life. With someone who's frail and elderly and has a lot of medical conditions, the benefits of that aggressive therapy are not as high, in fact, substantially less, and actually can cause more harm by further leading to deterioration of quality of life. So I actually think that it's just tailoring care to where it can be needed the most.
I was horrified watching some of the early TV news, and a guy was on a gurney, and could hardly, he was a feeble guy. He was in his 70s or 80s. He was being gurneyed out of ICU or out of the hospital and into an ambulance to go back to his assisted living or his nursing home. He could barely move a finger, and there were people lined up applauding at the hospital about this great victory of having saved this life.
Yeah.
And it just horrified me. And I've also been really horrified, and I think my major source of vicarious traumatization during this whole thing has been watching the moral distress and the just plain distress and trauma of healthcare workers who are doing things like back-to-back attempted resuscitations with people with COVID, who are putting them, the healthcare worker, at tremendous medical risk. And none of those resuscitations succeeding because the ingredients for success are simply not there. This is not a reversible condition. So I think in some ways, COVID has thrown into very, very harsh relief some of the irrational protocols and rituals of the healthcare system, the hospital systems, such as inpatient resuscitation when it's inappropriate.
Well, that's exactly a much longer standing issue that this has really brought to the surface. Sometimes I scratch my head and you walk through an ICU and you just wonder, what are we doing? It's not the cost, it's not the resources, those are all legitimate issues, but it's what are we doing to these people that's actually not advancing their goals, it's not helping them live a happier, higher quality of life. And this is a point where life just is probably not worth living. And many of them would choose that if they knew what was being done to them.
And there's almost like a taboo against using the word suffering. You know, I noticed that in our conversation, you're talking a lot about like, this is not in alignment with someone's goal of care. And that's very sanitized language for what's actually occurring. And I think that's why I love the term moral distress. I love the term comfort care because any layperson understands what that means. And I guess I almost challenge the palliative care community and the sort of slow medicine community within healthcare to start coming up with more common sense language that speaks to lay people. Because I'll tell you, I mean, I'm a layperson. I'm a smart layperson. I'm highly educated. It took me over a year to understand what medical people were talking about when they talked about goals of care.
Well, I think you're exactly right about the branding issue. I think the terms hospice and palliative care have such negative connotations. And yet, as I said, when you phrase it as extra services, that can mean something very different. And I think also there's it's very hard to conceptualize that more care isn't always better care. And I think we need to do a better job of explaining that to people. And, you know, even some of these interventions, like these medications like remdesivir and the steroids, and, you know, maybe there are some studies that suggest a benefit, and I'm not in any way saying that there's no use for them, but I think we're a little too quick to give ourselves credit for these advances that really have very small benefits, and they have a lot of side effects. And we're doing not just fast medicine, but fast research, and we're sometimes making decisions that these treatments should be approved. And that was actually the focus of our discussion last week with Brad Spellberg, who's an infectious disease doctor, and certainly had some questions about the approval of the convalescent plasma and some methodologic concerns with the remdesivir and whether it really does improve outcomes.
That's beautiful. And I would also suggest editing language and making a distinction between treatment and care. I would say more treatment doesn't necessarily mean better care. I think, again, from the lay point of view, the word care has connotations not just of a therapy or an intervention, but of being cared for, of nursing care, of being touched, of people being careful. And so a term like goals of care is quite confusing. Goals of treatment is actually easier to grok if you're a layperson. Anyway, so I just want to throw that out.
I think we need help of people like you who are journalists who know how to put the words together better than we do. So, Katie, I'm actually a primary care doctor. I do
Yeah.
most of my patient care in the ambulatory setting. So I've seen what's going on from the hospital more from afar. But the patients the struggles that my patients are having the most, and I do have a lot of geriatric folks, is there people who know that their time is limited. They have family that they want to see. They have things they want to do that really enhance the quality of life. And it's really what they live for. Um, and they're being told to stay inside a lot, and of course there's good public health reasons to do it, and it's the safest thing for them to do. And but I also see the harms that come about from the isolation, from being home. I had an older man who really wanted to visit his family in Boston, and he asked me, should he do it? And I didn't know what to say. Of course, the safest thing is not to go. On the other hand, I can see the harm it's doing him not being able to go. I don't necessarily have an answer for it. I'm just wondering if you had any thoughts that could help me guide my patients.
Wow. Well, I think first of all, to get away from this absolutist fantasy that we're going to reduce risk to zero in any of our lives. There was an interesting piece in the New York Times about kind of counterbalancing risks. In my own life, I don't go to the grocery store. I occasionally go, but I try not to go. And I do much more ordering online because to me, that's a very easy way of reducing risk
Yep.
without a very low burden way. Similarly, I wear a mask. I always have a mask even when I'm on a hike. But we're seeing people in our backyard. We are having groups of two. We're having dinner in the backyard at some distance.
Yep.
Because I don't want to go crazy. I don't want to become depressed. I don't want to lose all of my social connections in the service of reducing my risk to zero. So I think it's much more about what risks can people tolerate and what can they not. Like if your guy goes to Boston and he ends up getting COVID and dying in Boston, will he feel that that's okay? You
Mm-hmm.
know, or will he not? And I think there's a lot of pressure on older people to live longer for the sake of the family. You certainly see it in intensive care decision making, sibling conflict over this. I was very lucky in my family in that none of my brothers nor I pressured my parents to make that kind of decision. Um, but I think there's a phenomenon called social death. We've essentially put almost everybody in assisted living in solitary confinement for 3 months. And that can actually literally destroy the psyche. And there are people in the slow medicine group who have commented, one of them commented that their mother was in some form of assisted living, but she was pretty much on the page. And now the daughter calls and she's just singing. The mother is just kind of singing. And she's doing her best to kind of be with her mother in the singing. But there's clearly been a major, major deterioration as a result of all this isolation. And I've seen articles by doctors saying, we've got to do something about these draconian policies. I think one of the brightest lights I came across was that a for-profit hospice network in the South called Heart of Hospice jumped in New Orleans, and in 2 weeks they created a COVID positive inpatient hospice unit that allowed 2 visitors a day for all day and even all night if they wanted to stay. Everybody had PPE, everybody was masked, but they have broken through this kind of absolutist, well, we're not going to allow any patient, any visitors at all. I think the whole thing's a mess. There are a lot of places that hospice workers are being kept out of hospitals and assisted living because they're considered outside vendors, and all the outside vendors are banned. I think some journalist said, we cannot eradicate death. And we really have to think about the trade-offs. How much are you willing to give up in return for the hope that you're going to live longer? How much suffering are you going to endure in return for more time on earth? And that we've got to give people their autonomy to make those choices intelligently. I could go on and on about this, you know.
Yeah, well, I've really
Yeah,
tried to not.
yeah,
This is helpful. I've really tried not to tell people what to do and make decisions. I've tried to
mm,
educate them about risks and let
yeah,
them know that reasonable people might do different things, and it depends on what's important to you.
exactly. That these are values questions rather than technical medical questions in a sense. You know, I mean, it's easy to say, don't do the stupid things, you know, don't go out without a mask, don't go to a bar, don't go to a restaurant,
Yeah.
or don't go sing in the choir, you know.
Yeah, I think that's right. Well, things, for example, like eating in restaurants. I never really liked eating in restaurants anyway. I feel confined, so I've been totally fine giving that up. But I had a hard
Yeah.
time in Los Angeles when they closed the trails, for example, the hiking
Oh, that was
trails.
terrible. And that had actually just about no relationship to the medical risk. I mean, that's
Right.
what really got me about it.
There's
This was
definitely
something
been
that
some
was really helping
inconsistencies.
people stay
Yeah.
sane.
So Katie, first of all, I so appreciate how much time you've taken. Um, I want to end just by hearing about your take on the future. I tend to be an optimistic person. I can tell from your writing that you are too. But here I am 10 years after I first read that article. And, there was a movement, I actually right around the time of Obamacare, where I thought the concept less is more in palliative care was really starting to take a grip. And I
Mhm.
started to see some changes. But I've started to see some of the same old patterns come back with our healthcare system. And then I can't say they ever left entirely. I just saw some signs of improvement. Um,
Mm.
are you optimistic that things are moving in the right direction?
Um, well, I think the major problem is the reimbursement system.
Mhm.
And that is propped up by the fact that the medical lobbies, you know, the whole medical industrial complex is one of the three biggest lobbies in Washington. The money to be made from a new medical device is staggering. Um, and the difficulty of an oncologist trying to do palliative care when he's not reimbursed for it, but only reimbursed on this basis of this thing called buy and bill, where he gets a commission on the price of the chemotherapy, is scandalous. And I feel it has totally deformed the healthcare system and made it very difficult for people who don't have a university position to do the right thing and still make a decent living. So I do hope that maybe this COVID crisis will help create more pressure toward universal health care, Medicare for all. But that alone, I don't think will solve it. I mean, we're also dealing with cultural archetypes about help is right around the corner, technological utopianism, we're going to come up with a solution. All of this is problematic. I guess my confidence is in individual people and in their own common sense. And so I write to maybe to the early adopters, to the people who are willing to say, if I have a map, I'm going to be able to make more empowered decisions. I'm going to be able to support my friends and create a good sense of community. Um, I really, there's so much in flux right now. It really feels like time will tell. The fact that there are these movements within medicine, like High Value Care or the Loan Institute, which is an activist organization for medical people,
Sure.
yeah, that we will see this growing counterculture because people suffer. And my whole thing from the beginning is I want to do something about the unnecessary suffering. I mean, I know that we're all going to get old and sick and die eventually, and we're going to suffer. But the unnecessary suffering, the person in their 90s getting shocked by an ICD unnecessarily, that we could do something about. And so I don't know. I just hope we will find these turning points.
Well, I agree with you that payment reform is important, and I think it's necessary for real change to happen. But I really don't think it's sufficient alone. I think so much of it is culture. I think there's some lessons maybe from the patient safety movement. when consumers start to demand that accountability and, as you mentioned, that empowerment. And in fact, part of the reason I started this podcast, I had been writing a blog targeting doctors about the less is more concept. But I think when doctors get it, it's important. But I think it really needs. There's a tremendous opportunity for patients and journalists and communicators in Hollywood to start getting that message out there. So that's why I really enjoyed your writing, and I love promoting it.
Thank you. Well, I hope you have a filmmaker on your show sometime.
I'll need. I am here in LA, so
Yeah.
to find some good healthcare media people.
Yeah.
Well, I want to thank you so much, Katy, for taking the time. I am a big fan of Katy's work. Check out her book, Knocking on Heaven's Door and the Art of Dying Well, katybutler.com, or on Amazon, or the Slow Medicine Group on Facebook. Also, if you liked what you heard today, our podcast, Healthy Skeptic MD, check it out, whatever podcasting device you listen to, or on YouTube, and we'll see you next week. Thank you.